and we're going to bring everyone back for Q&A. I have a number of really salient questions that have come in through, I believe, the chat box that Carl has been forwarding. I'll try to synthesize a few in the interest of time, as well as I think a few are probably more relevant just for individual conversation with the presenter and the person asking the question. I'm sure that can happen once we get off. I did want to start out, with something for all of you that certainly has been on all our minds of late, but has been something I've been working on for a couple decades now, and that's issues related to equity and in rural America and specific to population health. And often those two terms are not spoken about in the rural context concurrently. Equity, the dimensions of rural equity and rural healthcare, rural health improvement. There are, I think, as many of us know, 13 million people of color living in rural America. There's 2 million plus immigrants. There's booming immigrant communities in probably 20 or 25 states. Many people who are not well integrated, well incorporated into what I call the traditional work of nonprofits, institutions, government, and on from there. So if I could just ask each of you, given our audience, what might be a lesson or an example or a tip you might have from either the work you've just described or your own, your broader personal professional experience, on how to make sure we are really incorporating the breadth of the folks who are living in the rural communities that we're all committed to be serving. So I'm not sure how the Zoom works in this four-person panel, but take it away with that question.
Alan, I can take a shot. I would certainly invite others to join me. But a couple things that come to mind. And one is recognizing, naming, acknowledging that there are racial inequities, geographic, inequity of all kinds exists, and we need to see it is important. And it isn't something we're always considering. And so I think that's like a very first important piece. I think another piece that shows up in our work and that we try and do within the community strategies group is expand our understanding of leadership and really remember that leaders take all forms. You don't get, the CEO isn't necessarily more or better leader than somebody, or know more about their community than somebody who is a mom who lives in her community. She might know more about what her community needs and the cultural norms there than that CEO or the elected official. I think that there are ways that things like participatory democracy, new and different ways of thinking about how you collect and engage the citizenry to make sure that a vision for a community and the decisions that are made really reflect the community. There are really interesting new tools and models and that matter. And it can be so basic too. I mean, providing childcare at meetings, not holding meetings at times when only people who are paid can show up. Like, these are very little things for those of us who get paid to be on a webinar. But if your job is to be a home health worker or to work in the fields, like, you cannot show up at those times. And then the final thing I would just note is I think it's really important that we think about kind of the cultural context, and that if there's a dominant cultural context that we're expecting people and others to fit into. At times, I'm saying this as a white person in an institution that has worked in power structures where that certainly has been my expectation at times. And I think I'm increasingly reflecting on and realizing how much that also needs to change, and that we need to be more open to lots of different norms. And I don't have answers there, but again, I'm acknowledging my own listening, my own growth and understanding that that there is a dominant way of doing things that just doesn't work and never has for millions and millions of people. And certainly my work with Native American nations is part of what has opened my eyes to lots of different ways of being that are so valuable and from which we can all learn. So being more humble and seeing with open eyes and asking more questions would all be other tools that I would recommend to anyone. And it doesn't matter where you work and what your sector is. We can all do that in our individual lives and in our work lives.
So I saw Rhonda nodding in an animated fashion, so take it away. You're on mute.
Sorry about that. Yes, so I agree. I want to tag off of that because I think that especially like within hospitals, we have got to get out of the four walls. We have got to get out in the community, and we have got to really meet people where they are and be willing to be uncomfortable with some of the things that we hear. So for what always comes to mind for me is a hospital I was working with that around a community health needs assessment. They did a lot of work, mostly white, that worked in the hospital. They were very dedicated to working on breast cancer. And yet one of the data said that one of the biggest populations that was really just suffering were the African American men with prostate cancer. And more men were dying from prostate cancer. And so we had talked with the minister of the local African American church, and he said, you know, if you really want to make a difference, come to my church. He said, talk to the men in my church at my church. Don't expect us to come to the hospital at 5 o'clock in the evening for a seminar on prostate cancer. He said, be at my hospital. If you're going to be doing some testing, I will be the first man in line, and the men in my church will be behind me. So it's about that humbleness that Katharine mentioned, but really getting out of the walls and getting away from what feels comfortable and what's the norm. Thank you.
Alan, one of the things that has influenced me on this topic has been the survey that was done, rural survey that was done by Harvard and NPR. And one of the things that was a theme in that survey was that not everyone in rural communities views issues of race and racism in the same way. The younger people have a more open, clear-eyed view, perhaps, and than some of the others, and that the different people groups in rural communities see things differently. So I think it's a complex thing when you look at a community to know that different people in the group are viewing the situation differently, and being able to be sensitive and respond to that is important.
Thanks, Karen. If so I don't lose the thread of one of the questions, someone had mentioned that we need to make sure that the importance of the extension service and the local ag extension agent was put in play in terms of the stakeholders who are not usually associated with population health. So I want to do that. The broader question, I think that's good for the group and reflects 2 or 3 different questions. All of this population health work is expensive. There's not the standard kind of funding mechanism for it. What are some ideas for the group about or some successes or tips you might have in terms of exploring financial support for population health work?
So from our perspective, we certainly are sensitive to who we invite to the table, how we have the resources to do our community planning. So it's interesting, Alan, that you bring up the Extension Office, because the Extension Office here in our communities are an integral part of the monthly meetings, the work that we do day in and day out. We include those and a variety of other areas as well. Fortunately, from our perspective, we have resources through the Center for Rural Health that helps us to do assessments, to do planning, to do those kinds of things. And again, by providers working together, there are health center funds that are available that we're able to use for some of this work. Public health has some resources that we put to use as well. The point being, collaboration helps minimize individual responsibility and the financial resources that need to be expended.
So Darrold is talking like a money whisperer who is positioned for sustainability, because he's talking about the complexity of this and all of the different sources and uses and how the collaboration is important.
So I'm going to give a really different answer. Not surprisingly, but for me, one is population health isn't expensive compared to sick care, right? Part of this is we have to change the narrative and we have to change our model. Going to the dentist is expensive to fill a cavity, but guess what? It's really expensive if you don't go to the dentist and then you need to have a root canal, right? Like we have to change the narrative and we have to command control so that we can actually change policy and actually have the money that we need. Because I think, the work that we are talking about in practical measures, it does cost money. And that the problem, as I see it, is that the funding streams that exist, certainly in rural development, and I think this is something we can say for healthcare too, is that the funding streams that exist generally are for the services, right? We have money to build a road. We have money to do water infrastructure work. What we don't have is the money up front to make sure that we have a smart, strategic, thoughtful plan that brings everyone together. And we don't invest it. We have at least on the federal front, and certainly when I think about many of the states that I know best, there is very little money for people and for local institutions and for coordinating and capacity building. Like the work of coordinating might save money in the long run, but it actually costs money up front, right? And we have to figure out how to align our federal policy so that we are smart in those investments in the long run, and that takes investment in the short run. And that's the kind of money, certainly in rural community and economic development, that just isn't there. There are a few $1 million, $100 million here and there, maybe, within USDA rural development, and billions, 23, 26, 28 billion dollars going out every year for infrastructure investments. So that's the kind of scale we're talking about. And I can't do those numbers for healthcare. That's not what I know, but I feel pretty confident in saying that we don't put nearly as much money into the front end and keeping people healthy because we don't value it. And we don't, we have 10-year budget windows that don't give you credit for savings beyond that. So I think taking back control of the narrative, emphasizing prevention, and then making policy change follow is an essential component, and everything that Darrold and Karen are saying, because at the local level, of course, you've got to be super smart and strategic to make it happen.
And Alan, this certainly isn't counterpoint here, but there are issues out there with value-based healthcare where there's focus on prevention rather than providing services. And so if those resources are used wisely and entities are looking for the future for that value-based care, we can really make a difference in folks. And there are insurance companies, Medicare as well, Medicaid as well, who pays you and helps you initiate preventative health, that type of planning as well, too, instead of just responding to acute onset of disease.
So a follow-up to that, which came in through chat, is, and I'm sure all of you have had some engagement and some very active engagement with philanthropy, private foundations, family foundations, healthcare conversion foundations, or if you think of philanthropy as corporate giving programs. What's the most compelling message you can provide to a philanthropist on why they should be investing in rural population health work?
I was thinking about the work, Alan, that was bringing together philanthropy and CDFIs and state governments around rural health. And I was also thinking about some of the work that the Federal Office of Rural Health Policy has done to bring together rural philanthropy, to think about how the federal government and the philanthropy might work together and what kind of opportunities there are for both learning and investing together.
I'm scanning the screen.
Yeah.
See if anyone else wants
I can come up with several different arguments, but I would say, I think one is that healthcare in rural is not working. It's not a workable model. We see decreasing outcomes in health status, and we also see rural hospitals closing. So there is a place where there is just a radical need for systems transformation. And if you want to make an impact, and foundations care deeply about impact, then this is a place to be creative and to be an innovator and be a risk taker and realize transformational structural change and make a huge impact. Maybe not if you measure every individual's lives, but if you actually measure value of outcomes and where people are starting versus where you might go, I think you have a tremendous place to help blaze a trail and actually be a risk taker that enables government and others to step in behind you and try models that have already been tested, tried and true. And only philanthropy can really help take on some of that risk and drive change at the local level. And like, why not?
Anyone else? Rhonda or Darrold? No. So we are moving towards the end. We're actually a little over time, given the robust conversation and presentation. So once again, want to thank the presenters. Want to thank the audience as well, given both the quality of the questions and sticking with us throughout. But I want to give the presenters one last opportunity. You can sell an idea. You can double down on something you said previously, or just take a minute or so each to kind of put a bug in the ear of the audience, and then we'll sign off after that. So maybe we'll start with Darrold, since he started first on the presentation.
Well, certainly, as this workshop has been, there's been diversity in this workshop, bringing together various experts to talk about things. And that's the important part about community collaboration as well, to bring together diverse groups, whether it's racial diversity, whether it's diversity in how we provide services to multiple age groups, or primary care, behavioral health. All of those create diversity in our communities, and the more folks we can have to the table providing input, the better it is for all of us, and in the end, for the patients that we serve.
Great. Thank you so much. Rhonda, we'll go in order.
I actually was thinking very much the same thing that Darrold said, and it is about collaboration, and it's about bringing the partners to the table that are not your typical partners, thinking really differently, again, about pulling in art, music, theater, businesses, the churches, anybody who feels passionately about health, bringing them to the table, and that this is not just an issue about healthcare. Thank you.
Thank you, Rhonda. And Katharine?
Sure. Relatedly, I mean, I think my mission and what I'm really interested in and really invite all of you to participate in is the work of bridging between community economic development and health, and coming up with intellectual frameworks and language that enables folks who are on the ground, who are doing this work in community, to see that they are partners and they are allies in doing this work. It doesn't matter whether you identify as somebody who's in healthcare, or somebody who works in water infrastructure, or somebody who does business development. We're all in the business of creating better opportunity, more opportunity and better opportunity, and better health outcomes for rural communities. And so we need to join hands and see that together we will have power if we work across geography and across industry and can articulate a vision together of where we want to go and why rural people and places matter. And so we'll be doing that work through Thrive Rural, an initiative in partnership with the University of Wisconsin's Population Health Institute and the Robert Wood Johnson Foundation, and certainly invite and hope that any and all of you will be partners in that work in the years ahead. Thanks for having me.
Thanks, Katharine. And finally, Karen.
Well, I really appreciate how complementary each of these presentations were, and how they fit together, and how they build on yesterday's work in this conference. I guess if I were going to say one thing, is to look at the whole system as it relates to seeing the money in the system. And if you're a money whisperer, use your skill, recognize that you have that skill and use it, and help be a leader with your community or region. And if you need to, then learn to be a money whisperer with intention and practice. Learn to see the whole system and the broader money in the system, so that it can be organized in a way that supports population health.
Thanks, Karen. And I guess I'll take my my opportunity also. I think from all the rural philanthropic work I've seen over the last 10, 20 years, the best work incorporates much of what we've heard today, this kind of multidisciplinary community partnering. But the way I describe it is we think of these rural places as places first rather than issue dependent. And the success of the community, issue agnostic, becomes the success for all. So I want to thank you all and thank our sponsors for allowing me to be part of this. And I think now we need to move on to our virtual lunch, which we'll think about each other perhaps, but we'll be in our own places. So thank you all once again. And I think that's a wrap.